to welcome you all to our RAAMHP kickoff. That's Roseville Area Advocates for the Minnesota Health Plan. And we're going to have, what we've done here is, I'd like to introduce Val out front there. She's the one that's behind this, getting this chapter going. Valerie right there. And she recruited 3 more people, and we're trying to recruit some more. So we're hoping to get this kickoff in this chapter off the ground. And just before we get started, we've had everybody sign in out there, and we really need emails because we don't have a budget for doing any mailings. So if you could stop out there on your way out and try, or if you want to go out there, just try and get your emails unless you absolutely don't want us to have them. That's all right too. So we're here to start our local chapter with the kickoff. Mindy Greiling will be moderating it, and she's been our representative for the past 20 years. It's been a couple years since she's been in the legislature. And John Marty, he's been working on the Minnesota Health Plan. He's had a bill come forward. It hasn't gone anywhere, but he's been working on that for I'm not sure how many years, at least a half a dozen, maybe closer to 10. So without further ado, I'll have Mindy come up here and John and get things rolling.
Thank you, Charlie. Good evening. Can you hear in the back? Okay, good. Well, yes, I have been out of the legislature for 5 years, actually, not just a couple. So it's fun to be here tonight with Senator John Marty, who I was always so proud to serve with. And I was always a co-author of the Minnesota Health Plan. And the reason that Charlie said it didn't go anywhere, well, it often had hearings. There were people like us in this room who were enthusiastic all around the state. Many legislators were very enthusiastic. The Health Care Committee legislators, often new legislators, campaigned on it, came to the legislature, and then traveled with John all around the state to promote it. But in the end, the inertia often always came from legislators who said they were our supporters. They were for single-payer health care. They were for the Minnesota Health Plan. But then there was always a but. But, you know, we need to do this little piece first. We need to have tinkering or incremental change or things like that. And so that's why it has taken a long time to get this plan. And so I'm so glad John has written his book and if you didn't get one, they're out in the entryway. There's a $10 donation, and if you didn't bring your money or that's a challenge for you, just take one because we want people to read them. I think this is a huge advantage from when I was in the legislature to have a comprehensive plan that, you know, John gets around, he talks about it, but to have more people have a chance to read it themselves and delve into it more than you can just in a half-an-hour talk that John's going to give here in just a minute when I get done here, is a real plus. And also, since I was in the legislature, we've had the Women's March, we have the indivisible groups, and I think people are ready for organizing, and that's why when Val Swenson called some of us to get organizing on this single-payer health care that we so desperately need, we said, yes, let's do it, and let's get more people. Each one of us in this room has a horror story of something that's happened in our health care and our lack of health care, and I'm sure some will share a brief line or two of their story when we get to the Q&A after John talks. We hope to have a half an hour of him explaining the Minnesota Health Plan, and then a half an hour of Q&A and just a little bit of next steps and how we're going to organize. And so I'm going to just give one little short story that happened this past summer. My husband and I and some of our family were in Belgium, and right before Bastille Day, my husband, who's kind of clumsy, tripped on one of the barriers on one of the avenues. And so he had to go to the emergency room by ambulance, and he had quite a few tests, and he was there a long time. 4 paramedics came with the ambulance to get him, and we were not charged anything. And I've heard this story over and over. A friend, Judy Berglund, some of you know, broke her arm in England, the same thing, emergency room, lots of care, no bill. Then one of our neighbors, a daughter, had a very small accident with a Portuguese man of war in Hawaii last summer. Hello, that's our country and our healthcare system. She went to the emergency room for 45 minutes. They poured some salt water in her wounds, and the bill, almost $2,000. So that's why we're here. For me, personally, the mental health system and the part of John Marty's plan that includes the mental health system is very important because we have a son with mental illness. And John's plan treats mental illness just as seriously as physical health. And one of the things people ask, and I'm sure we're going to hear about it in a second, how is this going to be paid for? And I can tell you one of the ways will be less emergency room care, less hospitalization. If people can get care that they need when they need it, then we have a lot of saved money. So, without talking anymore, because I want to hear Senator John Marty talk about the health plan, and then you'll see me again when he finishes to moderate the Q&A. So be thinking as he's going along about questions you want to ask. Senator Marty.
We're going to try a PowerPoint here. The projector's not super powerful, so we are going to turn out the front lights as soon as you get things on. Anyway, while we're waiting for this, we hope to scroll through and to work. Very pleased to be here and to have a chance to talk about this. And I think we could all, many of you, I assume, know people who have had serious problems with lack of access to health care. One of my first cases of it was a woman who came up to me about 9 years ago or so, shortly after we had introduced this bill, and she said, "We really need that bill." She stopped me at the event and said she wanted to talk, and we talked for a few minutes, and she told me that her sister, a 48-year-old registered nurse in the Twin Cities, had lost her job the year earlier, 2008, because of the recession. She worked in a nursing home, I believe, registered nurse, lost her job, and with it lost her health care, which is the way we do things in this country. And when you're struggling to pay the rent or mortgage, when you're struggling with everything else, looking for a job, you kind of, getting health coverage is something you put off. And she was, as a nurse, trying to diagnose her own condition and decided it wasn't urgent and it was getting worse. And at a family event, one of the family members picked her up. She lived alone, picked her up and realized how sick she was. She was in the emergency room the next day, and $250,000 later she was dead from a totally preventable condition because she gambled because she didn't have any money. A medical professional in this state, the Twin Cities area, dying because of lack of access to health care is not something we want to have. And so it's an issue I believe we can and must address. I've been pushing this for about 9 years now, and often you will hear people say, "Well, John, I like your plan, but it doesn't have a chance of happening." And I'll say one thing about that. First of all the other proposals I'm seeing for either party in Minnesota or nationally may be, well, we can fix this part of the problem. Last year the legislature spent $800 million to temporarily fix the problem with 5% of the market, the 5% that buys the individual market through MNsure, the exchange. $800 million to try and buy down the premiums and stabilize the individual insurance market for 1 year. What we're going to do after that, we don't know. The Republican majority decided one of the reforms we can get. Oh, okay, I'll go to it in just a second. But one of the reforms we can get would be to, Minnesota is the only state that does not allow for-profit health insurance companies in. You know, they decide, well, you know, the other 49 states are doing that much better, we better allow for-profit insurance companies in. How is that going to help? Well, when the problems are that healthcare is too expensive, a for-profit insurance company's financial responsibility is to their shareholders. And the only way you can enhance the shareholder value is either by charging more, which is the opposite of what they say they're trying to do, and bring down costs, or paying out less, finding more reasons not to pay out for expenses. So it's going the opposite direction. But anyway, I'll start with the slideshow now, and I'll try and get this going. But basically, the book I wrote was simply, as Mindy said, to try and spell out the ideas. A lot of people say they're in favor of a single-payer system. I don't even use that word much because people know they love it or hate it, but this is trying to develop a healthcare system that works. I don't know if you can see this all in the back, so I will probably talk some through it mainly. I described the healthcare system as sick. Obamacare covered more people but didn't fix the fundamental problems, and it didn't make it affordable. And now the system is going to get worse, and that is a prediction that I think is very likely. They were unable, group in Congress who tried 70 times, successfully 70 times, voted to repeal the Affordable Care Act when they had a president who they knew would veto it. Now has had a full year with the president who will sign it, and they haven't passed it once. And it shows that they realize they're at risk for trying to take away something without replacing with something equal or better. We can and must heal our healthcare system. What we've done in the last 40 years is largely tinker with the problem. We've had over a dozen healthcare task forces in Minnesota. I've served on several of them. They're good people on them. We work hard. But the end result is, I'd argue, tinkering with the healthcare system. Lots of changes, and we're going to tweak the insurance market here. We're going to try something new in delivery systems there. But bottom line is we're not making a lot of progress. What have we tried to do? Well, we recognize the problem. Healthcare is too expensive. That's one of the reasons people don't have it. So the solution is make it more expensive, more difficult to get. I mean, with any consumer good, if something's too expensive, you buy less of it. I would argue healthcare is not a consumer good. It's not I want more healthcare. People don't want more healthcare, and if you say you can have 3 times as much healthcare, if you're healthy, you don't really want to. I say we like our doctors, but we don't like to go visit them. So the solution, we're going to make it more difficult to get so they don't overuse it. How? We've used for 40 years now, HMOs use limited networks. You can go to these doctors, but not those. We limit that, that's one restriction. We use co-pays and deductibles, and more co-pays and more deductibles. We restrict coverage, things that used to be covered, you can't get coverage for that anymore. And then something called prior authorization, where a provider has to go get permission from the payer, usually insurance company, before they give you something. Used to be for very expensive, unusual things, you had to get prior authorization. Now there are cases where diabetics have to get prior authorization to get insulin every 6 months. And if you know, I'm not an expert in anything medical, but I've never heard of diabetics who all of a sudden don't need their insulin. But all these things, we've been trying to make it difficult for people to get health care. The result? Americans use less health care, but we spend twice as much as other countries. And we have worse health outcomes. Real quickly, what that means, how do we compare with other countries? Well, we visit the doctor less. This is a chart, I don't know that you won't be able to see it, but this is doctor consultations per person per year in 2012. This is 2, 4 right here. So 3 is Sweden, Mexico, Chile, New Zealand. We use more than them, we're the red line. Some countries like Japan, Korea, Hungary, Slovak Republic, Germany use many times as many as we do. It's not necessarily the best indicator of how good the healthcare is, but we're not going to the doctor way too much. Our health outcomes lag far behind. This is life expectancy. you can see some of the top countries are topping 83 years now, and Japan and some others. We are down here 4 years or so below that. We do beat out Mexico and some other countries, however. But that's one common indicator. Another one, infant mortality. This is one where obviously you don't want many. Iceland's down to 1 per 1,000 live births. Again, we are not at the good end of this one, but we're doing better than Chile and Mexico and some other countries. We're not doing the best at these outcomes, and we spend twice as much on health care. These numbers are 2012, but if you look at the new ones, they're all higher up. It's made about the same proportion. If you cut the US level, it was 8,400 or something in 2012. If you draw the halfway line, 4,200, you'll see there are about 8 countries there, and there are about 2 or 3 others around the world that are more than half of what we spend on health care. By the way, am I speaking loud enough to hear? Okay. But we are spending, with about 8 or 10 or 12 exceptions around the world, we spend double or more what people spend on health care. The others spend significantly less, but so on. That should raise 2 questions. The first is the moral question. What kind of society wants to make it difficult for its own people to get health care? And I'll use analogy education. You know, education is extremely expensive. You know, maybe if we don't give all the kids an education, it's cheaper. But that's not the way we want to do it. But it's the moral question. Why would we want to do that? Why would we try to do that? And the second one, the practical question. We spent 4 decades trying to make sure people don't use health care as much, and we're still spending twice what everybody else is. It's not working. Shouldn't we try something different? Need a new model. I'll suggest not consumer goods, because health care is not a consumer good. Consider other services we need. Police and fire protection. Nobody has to apply for new coverage. This is open enrollment time of year. Does anybody have to choose their health and police and fire? And you don't have to pay a deductible before you use their services, and you don't have to make sure that your service is covered by your plan. A civilized society takes care of its people with that and needs to do the same with health and dental care. That's just something that's a premise I would make. I think a society ought to do that. When you start a trip, how do you get a new plan? When you start a trip, you figure out where you're going first. I didn't start out with the idea, hey, I want this kind of plan. I actually put together a list of goals. Before you design a healthcare system, you map out the directions, spell out principles. I put together a bill in 2003. It was during the Pawlenty administration. The bill simply said the Commissioner of Health, the Republican Commissioner of Health, has to design a healthcare system on how, by the year 2010, I think it was, how Minnesota would meet these principles that I spelled out. Republican design a plan I'm going to like. Well, if it meets these principles, I'll sign on. What are the principles? First one is you got to cover everyone, no exceptions. Get into that more if you want. Cover all medical needs. And our teeth, I don't know why we in this country, it's historical obviously, but why our teeth are treated different than our fingers and toes. You don't need separate finger and toe insurance, but you do need separate dental care. Seniors get separate prescription drug coverage. And you might be thrilled to know in Minnesota, seniors have over 24 options for prescription drug coverage. Most seniors don't care about who the insurer for prescription drugs are. They want to get the drugs they need when they need them at a reasonable cost. Next one, we want to make sure patients are able to choose the providers they want. We want to reduce costs not by denying care, but by administrative and other savings. We want to make it affordable to all, and so in this case, the premiums. Affordable to all, healthcare is something that is almost inversely related in general terms to your ability to pay. Your need is inversely related. The sicker you are, the worse shape you are in, the more expensive you are, the less likely you are to have the income that's going to pay for those higher needs. It's not something, well, as your income goes up, you're going to need more. It's something that often is the opposite of that. So you want premiums based on ability to pay. You want to focus on preventive care, because the whole point of a healthcare system is to keep people healthy and get them the care they need when they need it. Some other ones maybe seem less important, but this is important. Make sure there are enough providers to make sure there's no unreasonable waiting periods of time. You need to make sure we address the shortages of psychiatrists and general practitioners, You make sure they're enough, and there's nobody in charge of that now, which is one of the reasons we have a problem. Maintain Minnesota's leadership. I would argue when I'm talking healing healthcare system, we've got some of the best medical providers in the world in Minnesota. We've got some of the best medical technology, the best medical research, best medical training and facilities. But the worst system of care. We want to keep the good stuff, but have a better system for accessing it. And this may not matter to any of us unless you're a provider, and that's that you ought to pay providers in a fair and timely manner. And because insurance companies and frankly government often does not pay in a timely manner, that's pretty important. Final one, we want to be simple and understandable billing system. I'd argue each of these principles are important. I don't want somebody to say, well, I can meet 2 of those. And I think if you look at the proposals you're seeing out in the Minnesota legislature, I'd argue other than this one, or in Washington from either party, what you're seeing is none of them. None of them are going to cover everyone. None of them are going to cover things like that, though none of them allow patients the choice and so on. So I designed in 2007, I became chair of the health committee, and I decided if nobody else has a plan that meets these principles that I hoped the previous health commissioner would do, I suggested let's design our own plan. What's the Minnesota Health Plan? It would be governed by those principles. The legislation makes those 10 requirements legally binding on the Minnesota Health Plan Board. It would focus on public health and well-being, not on profits or politics, and medical decisions left to the patient and doctor. I think that's a key one. How does it work? I'm going to suggest it's not a hard thing to explain. It's the same doctors, clinics, providers, same everybody used. The best way we can see what it means to a patient is what happens when you turn 65 the next day. You can still go to the doctor or anybody else, only somebody else, Medicare, is paying the bill instead of whoever you had beforehand. So it's the same providers and so on. All people would be covered, simple application form. The legislation actually gets to some nitpicky details, like saying application form can't be more than 2 pages long, because there is no reason to have even a 2-page form. But you don't have to say what your health conditions are. You sign up. Matter of fact, when Medicare passed in 1965, they enrolled 19 million seniors in a number of months. For 1/6 as much, 1/8 as much as they spent to enroll the 13 million people in the exchanges a few years ago, over a several-year period. How they do it was simple. Your name, your address, your age, oh, you're over 65, you're qualified. It's not that hard. MHP card everybody would have is good at any provider, no networks, and frankly our plan would say no co-pays or deductibles. That's a very poor way to make sure people get care wisely. People don't get care because of $3 deductibles for people on Medicaid and so on. We want to make sure we do it logically. And full coverage when you're traveling out of state. Families would pay premiums based on ability to pay to the Minnesota Health Plan. Some would say, aren't those taxes? Well, no, premiums are what we pay for health care. This would be independent from the rest of state government. The dollars might be collected by Department of Revenue. They collect things based on ability to pay with income taxes. Might be collected by them, but it doesn't go to the state treasury. It would be set aside separately, like the Social Security Trust Fund, to be spent only for the Minnesota Health Plan. It would be employers who no longer need to shop around, pick a plan each year, figure out what they got to do, and then spend all the time negotiating it, and then tell their employees what the changes are, which takes a lot of time. But General Mills, Vice President, a number of years ago, gave the best description of our healthcare system. He said, if you tried to design a healthcare system that doesn't work, you couldn't have done a better job. And why would a General Mills Vice President be so concerned about healthcare? Well, because he was in charge of the personnel stuff. And it takes huge shops for that. Employers now have an employer mandate. They wouldn't have any of that. However, they'd be paying a payroll tax to cover a portion of it. Providers would negotiate rates and compensation with the Minnesota Health Plan. That's important. Negotiating rates really does bring down rates. One of the theories of the Affordable Care Act was, you know, that if we have these big provider networks, they'll be able to cover everything, and so they'll be able to do things more efficiently. What they found out, a good study by a guy at Yale, I do talk about it in the book, in a couple of years ago, actually found out, the New York Times headline about his report was saying what the experts said about healthcare was wrong. Because he was saying, actually, the bigger networks, the bigger the Allinas and Mayos and everybody get, the stronger their negotiating clout becomes, and it's actually driving up the costs. But what we have, the reason I mentioned that is because we've got a very irrational pricing system. There was one study, it may have been that same Yale study, that went around to figure out what prices were, because prices are what's driving the healthcare costs. And for one kind of knee surgery, I don't remember details what kind it was, but they studied one type of surgery, just not a huge expensive one. It was $3,000 at the low-cost hospital, and often variations were whatever. He figured out the highest cost hospital he found it for was $55,000. Now, if you try and buy a Chevy or a Toyota Prius, let's say, and you go to a dealer in Maplewood, you go to one in Brooklyn Park or wherever the other dealers are, and you ask them, I want to buy a new 2017, 2018 Toyota Prius of this model, you won't have 15-fold price differentials. You might pay $1,000 more at one than another, but you're not going to pay $3,000 at one and $55,000 at another. There's a rational economic system there. We don't have that in healthcare pricing because you can't shop for it. No matter how much, even if the price is labeled, you go to the emergency room, you don't have a lot of choice. And the prices are at a facility vary by who it is. I got neck surgery at Regions Hospital 10 years ago. The bill came in, it was a nice, simple bill it was the estimate of benefits, it wasn't a bill. But it said the cost is over $21,000, and unfortunately my insurer only paid $7,000. I only had to pay $200. Who paid the other $14,000? Nobody. The only people who pay the $21,000 are those who don't have the insurance plan to negotiate the rates. Irrational system, but we negotiate rates. It would be governed by a Minnesota Health Plan Board, which would be democratically selected based on county boards around the state electing regional health boards who would elect the state health board. Board and CEO, I got into some minor details in putting together the bill because of some really serious problems we got with our current system. And we would cap, we don't want super high salaries and stuff. The board would be compensated at the same rate as our Public Utilities Commission. The CEO would be capped with the top agency commissioners, about 130% of the governor's salary. We're talking a couple $100,000 for the top dog at the plan, not, well, CEO of United Health Group a few years ago was $100 million a year. We want to avoid that, so some of those details spelled out. The board would administer the health system bound by the Minnesota Health Plan principles. The board could contract out the one thing insurance companies do now that you need some of, probably 1/50th as much, but claims processing, they could contract out with one of the providers who do it now, one of the health systems that do it now. Board negotiates prices and would be required to act to end conflicts of interest. Some very expensive machinery, radiation oncology. If you go to St. John's Hospital in Maplewood, you'll find there's a radiation oncology avenue at, I think it's 1575 Beam Avenue. And there's another radiation oncology clinic at 1580 Beam Avenue. The numbers are basically across the street from each other. Why? Because the hospital wanted a radiation oncology thing, they felt they needed one, and this was before the state started saying you can't put them anywhere you want. And so doctors said, hey, we can make money by referring people to our own, and they put one across the street. We want to end those conflicts of interest. Would have an Office of Health Quality and Planning to ensure enough providers. They'd be legally bound to that. People say, how are you going to do that? And I'd say we have a shortage of general practitioners. We have a surplus of a lot of specialties. What are you going to do? Tell the med students what they have to do? No. If there's somebody in charge of or saying, you know, we're short of we're short of general practitioners or something, especially in greater Minnesota, well, we'll work with the med schools and we'll say, okay, we'll pay off your tuition, or we'll pay off your student debt, or buy down your tuition, or we'll pay you more to practice in these communities. It's not hard to do if somebody's in charge of making it happen. Strengthen public health and prevention programs, integrate them into the health system. We have some good ones available, but they're hit and miss. They're based on other budgets that state and local governments have. Focus on improving quality, focus on saving money. And when there are ideas on how you can integrate these new things, you can change them right away. You don't have 50 insurers you have to negotiate with before, well, will you cover this instead of that because it's more efficient. We'd also have an ombudsman for patient advocate. This is a person who's totally independent. This would be the only political appointee in the entire process. The governor would appoint the ombudsman for patient protection. Because of the fact that you want them to be independent, this person would have legal authority and power and funding to investigate complaints and concerns, and the authority to force the board, legal authority to force the board to make changes. But that's roughly what it would do. I would say the Minnesota Health Plan could be described as Medicare Plus, Medicare for everyone over 65 and for everyone under 65 as well. And it could be described as Medicare Plus because it covers all current benefits plus dental, plus no co-pays and deductibles, no donut hole, no anything like that. And it includes long-term care, which is very expensive. And I'd argue 3/4 of all health care in this state for nursing homes is paid by government already. All the fight we have trying to get people to buy long-term coverage, all the fight we have trying to recover money from people who try and shift it to their kids to avoid it, and all those efforts, all of that is based on 25% of it. How do we afford it? The obvious question, we can't afford what we're doing now, we're going to add more people for more things. It's counterintuitive, but all the economic analysis around the country and real-world experience says it's actually less expensive to do this. What is single payer? This is a single payer system. Again, I don't use the term I said, it's not very descriptive. If you tell me you buy a new car, I say, what kind? You say, dealer financed. Yeah, but what kind of car did you buy? You don't tell me much by that. Single payer doesn't tell you much. System where everybody and all the providers are paid by one entity, not hundreds of different entities. It's not very descriptive. People know they love it or whatever. I'd argue it's probably the only way to get universal health care in the United States. Germany, Switzerland, a few other countries have multiple payers, quote, insurance companies, sickness funds they're called in Germany, and they do have virtually universal health care. The difference is, and I looked at the German system a number of years ago, I went over there, and it was interesting, I was there with some health insurance executives here, and they were saying, you know, you guys need the ability to compete like we do in America. He said, you can't compete on price because they're told what they have to pay the providers, which providers they use, they can use any provider, which patients they accept, they can take anyone, what they cover, all of that's all determined. You guys need the ability to compete with each other. I'd say, yeah, they probably do because it's patently obvious over there that they're not adding any value. And the bottom line is our country, the difference is instead of government telling insurers what they are going to get, what they're going to do, in our country, the insurance companies tell the government, here's what we're willing to do, here's what you have to do. I'd argue it's the only way. Now the cost, I'll give you one quick chart here. You probably can't see the details, but in 2007, Colorado had a process like our healthcare reform commissions, only they said we're going to do this to try and tweak the insurance thing and this to do this to save money here. They instead said, we got problems. Healthcare is too expensive and a lot of people don't have it. Give us your best ideas. A request for proposals, an RFP to the public at large. 24 groups came in. They picked the best 4. They thought a lot of them were similar. They whittled it down to that, and then they hired the Lewin Group, which is a health economics consulting firm, to do an analysis. 200-some page report. I made a chart out of it because I thought it was helpful. I'm not going to describe what the plans were. The only thing I'll mention is the bottom one is what you call a universal single-payer healthcare system. And the first one, they started with 800,000 uninsured. This is before the Affordable Care Act. And I'll just tell you the numbers. First 3 plans cut it down in half, and by 5, 6 or more. The bottom plan doesn't have hundreds of thousands. It has a 0. It's a universal healthcare plan. It covers everyone, which was one of their 2 goals. The cost. First one, well, the numbers, they range from $271 billion to $1.3 billion. The universal one has the highest number of all, but a little minus sign in front of it. It saves $1.4 billion. So what did Colorado find in their proposal? Only one plan covered everyone. Only one plan saved money. Only one plan worked. But they decided it wasn't politically feasible. So of course what we do in our political system, well, we'll find something that's feasible and fight for that. Well, I'd reframe that same thought and say, well, what we do is, if only one plan works and we decide it's not politically feasible, well, we'll fight for something that doesn't work instead. And that's really the same phrase, I just turned it around a little different because that's what I think happened. I'd argue maybe that's how we ended up with the Affordable Care Act. Barack Obama in 2003 said he thought the one way we could fix healthcare would be a single payer system. This cartoon is a big sign, says stop and think. The bottom one guy's looking at it, says the other, sort of makes you stop and think, doesn't it? Now, I just told you that we're going to cover a lot more people, and I better wrap this up.
Could we tip up the
projector a little bit again?
It's hard to read.
Well, let's see.
Okay, so we'll try. Anyway, while she's tipping that up, I'm going to say that when I told you we're going to cover more people for more things, and we're going to save money, and we're going to do some through administrative savings, and some of it through price negotiations, I think people, the number one expectation I would have is true skepticism. You can't save that much administratively. But I'll suggest for a comparison to help understand is the way we fund schools and the way we fund hospitals. Compare them. What if we were to do schools the same way? That'd be a lot of changes. First of all, teachers would spend time, I don't know, I'd guess half an hour or more a day to calculate how much time they spend with each student, how many supplies they use, and so on. School would have a billing office. The Roseville schools, St. Paul schools, as far as I know, none of them have billing offices, but they'd have a billing office pulled in the janitorial costs, the overhead, the capital costs, and then they'd allocate it to each student. Parents would purchase school insurance plans, and they're expensive, so employers would step in and provide coverage for their employees' children. And of course, not everybody has that, so families without it could buy in the individual market, and again, because it's expensive and they may be less likely to, government could step in and subsidize the premiums. Then they'd send monthly bills to all the school insurance plans, and they wouldn't be at the price that you might expect them to be. Like a hospital has, if anybody works in a hospital, they have what they call a charge master, which basically inflates prices to some irrational amount. I'd argue largely because they know they're not going to get paid that anyway, so they negotiate it down. But they start out with a charge master price, and the insurance plans then negotiate for a better deal. If you can't afford the school insurance, like I suggested with my surgery, instead of $7,200, which was paid for, it would have been $21,000. If you don't have a school plan, you're going to be liable for the full amount. You probably can't pay it, however. And many families, even with the insurance, can't pay the co-pays and deductibles. So the schools need not just a billing office, but also a collections agency as well. Is this going to improve education? Of course not. It's going to take teacher and administrator time away from teaching and education and into billing, to say nothing what parents have to do. Think how much time you spend on looking over. We just had our state open enrollment a couple of weeks ago, and think how much time you have looking at these options and that, and how much you set aside for that. Parents are spending all their time shopping around for it too, so it's taking time away from students and everything. It also means students might have to be switching schools if they switch employers, different school plan, and they're out of network. And some students have no coverage, so they'd be denied education. Of course, we could do what the hospitals often do, and that is we provide uncompensated care and shift the cost to everybody else, and I'm sure some of the schools might do that and just shift the bills to everybody else. Is this going to save money? Of course not. It's going to have a huge new bureaucratic cost. And again, here when we talk about the public option, which I will support as a tinkering thing in the meantime, but if we had a Blue Plus for education, and maybe Health Partners might have a branch that Education Partners, and UCare could be ULearn, and so on, they'd all be out there, and it might be Minnesota Care could have a Minnesota Learn branch, and it might provide better coverage, better rates, more comprehensive stuff, less hassle. It might do that compared to the other plans, but fundamentally, why do we want all these school insurance plans? Why do we want that cost? And actually, the cost of doing that with the schools would be absolutely enormous. It would be a terrible waste of money. This is a chart that came out a number of years ago. This is growth in physicians and administrators from 1970 to 2009. That little brown line is growth of physicians. It's a very compressed scale, so it's about a threefold increase in physicians over 40 years. Administrators have gone up, health administrators have gone up over 3,000%, 30-fold increase. Why? Because we're getting a more and more convoluted system, spending less time on healthcare and that. With that, I'm ready to open it up for discussion. That book, the book, by the way, you can also download it for free. If you know people who might be interested, just go to mnhealthplan.org. I'm not making any money on the book. I committed to that ahead of time, so I feel free to promote it because I want the ideas out there. And with that, I look forward to the discussion.
Actually, I just realized we only have one microphone. I was envisioning myself running around the audience with the microphone, get the questions, but this program is being recorded. So do you want to repeat the questions? Okay. All right. Well, I'm going to take the facilitator's prerogative and ask one question before I open it up to the audience. So, John, could you tell us can you give us hope with the climate at the Capitol, or what could we do? What are two things that those of us in this room that could do to help you and to build this ground movement? Because you and I, unless things have changed in the last 5 years, I think it's going to have to come from demanding of the public. I remember when I first came to the Capitol, you were working on campaign finance reform, and I joined you in that. And the only way we got it, because legislators were not really wanting to do that, or the gift ban, was because the public spoke out, the newspapers demanded it, and then it made our job easy as people there didn't want to do it, but they did. So what can you tell us to give us hope, what we can do?
I will agree with you that, frankly, it is public pressure that makes things change. Yeah, it was a couple of scandals that made the public pressure happen on campaign finance reform. Things do change. Sometimes, Mindy and I both had some legislation that you had a great idea and a year later it was part of our law. There are other times I've fought for things that took 20 years and so on. But in terms of giving hope, the book was published last September, I think, with the hope of this January being able to push for it. 2017 was the year the Affordable Care Act gave states the option to get what they called an innovation waiver. They waited till 2017 too, so I was hoping this year we could push for it. I figured it was only a 1 or 2% chance. There's pretty strong odds, pretty strong opposition to it, but I was thinking 1 or 2% chance. Then the election hit, and that massive 1% or 2% opportunity that I saw earlier evaporated. And frankly, small opportunity in politics, you jump on it because sometimes it happens. And people who don't think that works that way, I'll give 2 examples, one of which was how many people 5 years ago would have thought we'd ever be taking Confederate flags down from state capitals. You couldn't predict that. Gay marriage, I think people didn't foresee that coming. I thought it had a chance of happening, and it did happen faster than most people thought. You can't predict these things. Public pressure makes a huge difference. There are signs of it changing. President Obama, when he signed the Affordable Care Act, the person he called up at the bill signing to give credit to the bill design was a U.S. Senator from Montana named Max Baucus, who had made some notoriety among people who supported universal health care a year earlier when he began the Senate hearings for what became the Affordable Care Act, saying the only thing he wouldn't consider was single payer. Why? Because it didn't have a chance. In one hearing where some doctors and nurses stood up and demanded he consider it, and they shoveled them all out of the room. He said he didn't think it had a chance, so he wasn't going to consider it. Max Baucus told a group in Montana a couple of weeks ago that he actually now thinks single payer, it's the time for it, we need it, and it's going to happen. Unfortunately, Max Baucus is now retired in Montana, and it would help a lot more if he had done it 10 years ago when he had the chance to do it. A couple of years ago, in terms of the hope, though, so he's changed his mind. A couple of years ago, the U.S. Senate, there were no bills calling for a universal health care system. This year there is one, and there are 16 co-sponsors of the bill. I would not describe them all as strong advocates for it. Like I'd say the 60 co-authors I have for my bill now, I'm not sure they're all wildly enthusiastic. They heard from constituents, sure, they'll put it on the table as something to consider. They signed on. One of Minnesota's senators signed on with a really strong commitment saying, well, Paul Wellstone supported something like this, and so we ought to consider it as one of our options. Why do they do that? Because they're scared. Politicians, I think there's some of us who aren't scared all the time, but politicians are very scared of public opinion. And what are they afraid of? They are afraid if they support something like this, they're going to be attacked for being socialists. And my message to the ones who went way out on a limb to support this is, first of all, it's not way out on a limb, and I tell them, you know, what were you called 10 years ago when you signed on to support the Affordable Care Act? Socialists. They were attacked the same way, the same words, the same everything else, and it wasn't like they're going to attack them harder now. The opponents are going to say, they're going to attack them with everything they can. But when these senators go out there and they say, they give, well, you know, we ought to consider a universal single-payer system, and maybe pharma doesn't like it, maybe insurance companies don't want it, but, you know, I think we ought to consider that at least. They get people applauding and saying, about time. This is long overdue. And when politicians hear something really positive, they start using it in their speeches, and they get more applause, and they start talking more about it. I actually think they have a better chance of winning an election by talking about something that makes a difference, something that would solve a problem. And when they start doing it, if 16 of them are doing it now, I actually think it could change the direction of things. That's item one. Item two on the answer, I'm sorry it went so long. Item two is that when the Trump administration came in and all the other things happening this year, as I said on the first slide, I think things are going to get worse for healthcare. And I think my massive 1 or 2% hope this year went away, but I actually think for 5 years from now, I think it's quadrupled or better. The odds have gone way up in the next 5 or 6 years, just because the healthcare system is being crushed by its own weight. And frankly, the mainstream political forces on either party have no solutions. I mean that. I think they're saying, well, we could do this, it would help with this. It would help bring down the cost of this a little bit, and maybe if we have a competition between insurance companies to help it. They have no answer, so I think it's actually, it's going to come. Sorry about the long.
Now, since we have one microphone, I think it would make sense for you just to do the questions, and I'm the hook when the time is up.
Okay.
And I would ask, you can see that, and those of you who know Senator Marty, he always gives a very thorough answer. So when we ask our questions, it could be as brief as possible so we can get in as many questions as possible. So I'll turn it over to you, and in a half an hour, I'll be the hook.
What kind of support do you have from the health community? Doctors, administrators, hospitals?
It's a good question. What kind of support do we have from the health community? In the 1960s, when there was talk of universal health care, 1940s, 50s, 60s, the AMA was strongly opposed to it. They called it socialized medicine. There was a survey in Minnesota Medicine, which is the Minnesota Medical Association's journal, about 8 or 9 years ago now, that it was a survey they published. They felt it was scientifically valid and so on. It said about 65% of Minnesota physicians think a single-payer system is the best way to deliver health care. And that's not uniform. I mean, general practitioners, pediatricians are the ones who are most supportive. I think radiation oncologists and certain specialties are the least supportive. But overall, according to that, about 2/3 of Minnesota physicians were. I think there was a new one nationally of physicians that suggested over half now think we should come this way. Minnesota Nurses Association is strongly on board for this. It's one of their priorities now. Hospitals, I spoke to the Hospital Association a number of years ago. I thought they should be much more enthused about it. They didn't seem to be as enthused as they should be, but if you look what's happening in healthcare, I'm not surprised at that. I think hospitals have become, it's a huge profitable thing. Even the non-profits are hugely taking over some. But there's mixed support. Some in the medical community hate it. Most are coming around to it, and I think it's partly because they're getting bogged down in the paperwork, and physician burnout is a huge problem. And allowing physicians and nurses and providers spend time with patients is something a lot of them think is a good idea. Over there.
I want to congratulate you and thank you for being as clear as you are on such a complicated topic. It gets to be long with an answer, but could you just tackle a little bit in some distilled way the challenges of having this kind of plan in just one state? I mean, for the country, I'm sure most of us are sold, but how does it work when you're here with multi-state, multinational employers and with people around who might come running if it's all free, you know?
Good question. How can we do it in one state instead of nationally? I could start by responding to the first part of your question by saying, one prominent American politician said about a year ago, "Who knew healthcare was so complicated?" And it is incredibly complicated, and frankly, we're making it more complicated in many of the things designed to get payment, to bring down the cost. We figure some new bureaucracy is going to help us bring down the cost better. Complications in one state are multiple. Vermont talked about doing this. They didn't design a plan. They started out by designing a plan they thought was politically saleable, and in a tiny state like that, you'd have huge problems. The bigger the state, probably the better you are. You could certainly, with 5 million people, you can negotiate pretty well in a pretty fair system, and you could design a system, I think this does that, that would work in a state like ours. There are challenges to it. One of the things we do is if you travel across borders, this covers you the same as the plan I have is state plan through Health Partners, and if we travel out of the state or out of the country, we are covered the same as we are here. It's maybe out of network for a lot of things, but the Minnesota Health Plan would cover you that way. So the fact that you come and go from the state isn't a big problem. People who live in Hudson, Wisconsin, work in Minnesota, you can deal with that. Their employers in Minnesota would be required to be paying into it, and they could buy into the premiums for themselves and their families. So the border issues aren't a huge issue. And if you live in Fargo, in Moorhead, you might be going to your general practice, might be in Fargo. So you can deal with those border issues. The other ones you have to deal with, though, are the ones you sort of mentioned. Aren't people going to come there to get health care? And what we'd be asking for, and I'm not saying any of this is easy. Passing the bill is the most difficult thing. But trying to get the federal waivers we want would be very difficult as well. I'm not trying to gloss over that, but one of the waivers we'd be asking for is to say, if people come here to get health care, I'd love to be the way they are in Belgium and England and other countries where, you know, they just, hey, you're a guest in our country, we're going to cover you. But in our system where other states have a lot of people who aren't covered because they got very expensive things or they got huge out-of-pocket things, we can't have just everybody coming here. So we'd be asking, and this is a big request among the waiver requests, but we'd be asking the federal government to say, we can build the other states for people who are coming here to get health care instead of because their own state. And it would cause, I think it would draw a lot of businesses here. Matter of fact, with the Amazon bid, I suggested instead of the state offering economic incentives, which to the governor's credit, they didn't end up doing. They tried to offer, here's what we have. I suggest, why don't you offer the Minnesota Health Plan to them? Because frankly, while they'd have to pay their share of it, they wouldn't have to worry about their employees all being covered. They'd lose all the hassle, and whether they come or not, it would help every other business and every other family as well. So, but it would draw more businesses. One of the things a lot of employers find out is our country is very expensive. You know, in all the talk now about the federal tax reform to bring down corporate taxes. Warren Buffett last spring told his shareholders at their annual meeting, he said, American businesses are constantly complaining about corporate taxes. He said, you know, in the 1960s, that was 4% of our economy, 4% of our gross national product. Now it's down to 2%. He wasn't saying they shouldn't complain about it, but he says, you know, healthcare was 5% of the economy back in the 1960s. Now it's 17%, and businesses pay a huge chunk of it, and we're not complaining enough about that. We're trying to do something about it. He called healthcare costs for businesses the tapeworm of economic competitiveness. This is a good, it's insidious and eating away at it. But so it would create more jobs for people here. But the biggest issues are those ones, the border ones, how people deal with there. And frankly, there would be, like the city of Duluth had a huge fight several years ago because they guaranteed for their public employees until 10 or 15 years ago lifetime medical benefits. And they didn't set aside enough money for it because the cost went through the roof. They actually have some money in reserve, maybe not enough to cover the whole cost, but they have money in reserve, and we'd be asking if we're covering their folks that that'd be the first payment into it, or they give us the money, we cover it all. But supposing you're a 3M retiree, you got all your retirement medical costs covered, we'd be asking for that and then taking over for that. And if they move out of state, they'd get what they had already. But the thing is, there are complications, and we shouldn't gloss over that. Frankly, if one state passes this, I think you're going to have a lot of states trying. I think you'll have it nationally within a decade. That's what, frankly, what happened in Canada. 1962 in Saskatchewan, it was less than a decade, and everybody had it. Yes.
I worked for MFIP in the 90s with employment. I was an employment counselor for people moving from welfare to work, and I found that most of my clients were from Illinois because they moved to Minnesota because the benefits were so good here. So if we get single payer or this health insurance plan, we're going to have an influx again of new state residents.
A couple of things on that. One, and you work for MFIP, not me, but I looked at the demographic information each decade from the census. I haven't looked in the last decade or so, but from the 70s on, we actually, Minnesota always had a net in-migration of people below the poverty line. If you counted total migration, if you excluded foreign immigration into Minnesota, just state to state, we actually had more low-income people moving out of Minnesota in the 70s, 80s, and 90s than over the last 2 decades. So there are people moving in, and frankly, yeah, if you are struggling in Chicago, you may come up here to do it. You also have some downsides, colder weather and so on. But the bottom line is most people moving for a lot of those things, and again, I'm not a demographer and so on, but I do think that there's certainly some of that, and that's why I'm arguing that we'd have to do is, we'd have to be able to bill other states to deal with that. Because, yeah, I mean, if I got cancer, and well, right now we have no lifetime caps and everything else, but if I'm paying medical bills that are multiple times what I can afford, and yeah, that sounds like a better place to be, which is why that point, that question is the huge one. You have to make sure we address that, because otherwise people have the incentive to do that. We've allowed, among our counties, we've allowed counties to bill other counties for services. Hennepin County Medical Center and regions used to be, well, HCMC mainly takes a lot of patients from around the state, and we allow counties to bill each other for various things. But that's a very important point, and that's a good question in both ends.
So who or what is the most powerful opponent?
The most powerful opponents, I'd argue a number of them. Largely people who are benefiting from the current system, and that's growing every year. Everybody finds there's a new business now that comes in, and they offer a service to businesses for, I think, like $500 an employee, or maybe it's only $200. It's not too much per employee, and they will simply catch the medical errors, the billing errors they get for all the patients, all those employees' medical bills. And they say, oh yeah, probably every third medical bill has errors on it, things that you or I couldn't catch, but this company is set up to do that. That company, I'm not saying they'd be opposed to this, but their whole business model is making money off the healthcare system, and how much healthcare are they delivering? Zero. Mm-hmm. Bill McGuire, the CEO of United Health Group in the past, he's a physician. He wasn't providing medical care there, he was largely denying medical care. And all of those entities are not providing any healthcare. So pharma, big pharmacy is one of the huge ones. Insurance companies would be one. And again, by the way, I didn't get into this, but one of the challenges that often people talk about, one of the biggest political obstacles, is we would have some significant change, a lot of people losing their jobs. There was a study of a single-payer system in Minnesota a few years ago, an economic analysis. The Lewin Group did that one as well. It said there'd be about almost 40,000 people losing their jobs because they're working in benefits and so on. And by the way, when I mentioned that Colorado study earlier, I point out that the Lewin Group was the economics firm that did the analysis. And lest you think they were biased in favor of single payer, the parent company of Lewin is United Health Group. And I can guarantee you they are not biased in favor of a plan that would put their boss out of business. But But all those folks, those 40,000 people who would lose their jobs, which is almost 1/4 as many people as switch jobs in any given month. We have about 160,000 people switch jobs in a month, either leave a job, either to go to a new job or to retire or whatever. So there's about 4 times that much churn every month in employment, and about 1/4 of that one-time thing would be a huge thing. Our bill would require, one of the requirements of the bill would be it provides dislocated worker benefits, retraining, and everything to those 40,000 employees. Again, like Bill McGuire, the CEO, he wouldn't need retraining. He's a physician. Probably couldn't meet the salary again, but and the other thing is people who are laid off, because that's a huge hit. If I'm working in the field and I'm going to lose my job because of it, I'm going to be opposed. But I think the reality is we have a financial and a moral obligation to take care of those folks who are displaced from it. But nevertheless, that's a huge political force in opposition. It's, you know, when you look at all this, and I could give you 20 other arguments of why it's almost impossible to do, which is why Mindy's first question was, what is their hope? And I'd say, well, you know, whenever I think, oh boy, this is really long shot, I gotta say, what we're doing now is really a long shot that we can continue doing that, because it just doesn't work. Other things. Yes?
With this kind of a plan, all the employers would no longer have to furnish health care to their employees.
Right.
So there's got to be a huge ally with this, you know, with all the businesses in the state, right?
I would argue the question was if employers no longer have to worry about health care for their employees, and they have healthier employees because they don't put off going to the doctor and everything else. I would say it should be a huge selling point for employers. A number of small businesses are very supportive. There's a guy in Pennsylvania, a fairly large manufacturing company, who put together his own video. I think it's called Fix It. You can download it for free online. It's a 45-minute documentary or so on why he thinks single payer is something every business ought to embrace. Most of, we've got a copy of it there.
But it's available on the website.
It's on the website, yeah. So anyway, but most businesses have not been supportive, and I'd argue that what happens in the business community, the Chamber of Commerce, Business Partnership, who lobby for them, they, at the Capitol, on healthcare issues, they very much oppose it because some of their members are insurance companies and pharma and so on. They're going to oppose, they stick with all their members. We're not going to divide our members. Same thing, look at climate though. I mean, the Chamber of Commerce has argued in Business Partnership. A lot of those businesses are now saying, hey, we support the Paris Accords. We want this to happen. We're committed to addressing that issue. But they work on, Cargill and those companies work on those issues when they're at the Capitol. Who lobbies for them on other things like climate? The Chamber, which argues opposite what they say they care about. I think the business community ought to be some of the strongest supporters. I'm actually taking that blue book and writing a very similar one with a red cover, trying to make the same title, Healing Healthcare, Conservative Case for Comprehensive Common Sense. And I'm not doing that with the belief that, I'm not trying to pretend I'm something other than I am, but I actually think I want to focus on the issues, the arguments that business community, conservatives, that Republicans are making, and make the case, because I can't picture a lot of rational ways they could do it. You could disagree philosophically. I don't think everyone should have health care. There's some people who feel that way. Surprisingly few, actually. You know, I could go on about it. Way in the back.
So you had mentioned that people would pay based on what they can afford. So I'm wondering, do you have any kind of an idea how that would be determined? And then also, let's say you could implement this next year. Any idea as to what the premium would be for the typical family of 4? Yeah.
Good question. What would the premiums be? How can we determine that? What is it? Well, we've been trying for a number of years. Governor Dayton put $500,000 in his budget to do an analysis of a plan like this compared to what we have now. It didn't pass. The legislature did not accept it. I think we definitely need that. Before a bill like this could pass, And again, because of things like that, it could not pass even if we had the votes next year. If it did, it would take 2 years. We expect a 2-year implementation once the thing was finally passed. What the premiums are, we're trying to, Minnesota nurses have some people who are trying to dig into if you had this much, and they're figuring out what we're spending now. Again, the analysis suggests, including the analysis the Lewin Group did of a similar plan, was that it would save money, I think it was like 10% in Minnesota, and they suggest a median household family under their model would save about $3,500 a year. But we don't have that. It's too early to tell you that, but they're trying to figure out, well, if we were to need, they say if we spent $51 billion on healthcare in Minnesota last year. The projection there would be $55 billion this year, probably close to 60 next year. And to pay for that, figure out, we're paying it now, and again, more than half of it comes from government already. But if we're paying that now, how much would we have to charge in terms of a payroll tax for business? How much would we have to charge in premiums based on income to do it here? And you know, it's scary how to deal with these big numbers, and we can't tell people this is how much you're going to pay. We could make up numbers, but that's not very helpful to people. We're trying to get an economic analysis, and we're trying to do both sides. One, what it would cost, and two, this is something we can do ourselves by getting estimates from Department of Revenue. If we needed, if it's $55 billion this year and we needed to pay $55 billion into it, and we get this much from the federal government, this much out of the state government, how much do we need in a payroll tax? How much do we need? What kind of premium scale would we need? That's the kind of thing Department of Revenue and others can help us with. So we're trying to do that analysis now. But I wish I could tell you this is how much it is. I can tell you overall it should be less expensive based on all the analysis. And people are healthier. And you know, we had somebody said about, well, one of the savings you have is less emergency room. That's absolutely true. There are 33,000 visits to emergency rooms in Minnesota every year for dental care. And there are no dental chairs in any emergency rooms. Actually, HCMC now has one right next door. But all you do is you go there in the emergency room, they may give you Novocaine or some other pain relief, and they tell you to go, they won't pull your teeth even. They'll say, we'll come see your dentist in the morning. You don't have a dentist, you go in twice or 3 times. What a stupid, painful way to treat people. So, yeah. Other things, do you have a few more minutes, Min?
Yes.
Okay, yes.
My husband and I had lived in Australia about 35 years ago, and how they did it, because they had a universal plan, they just had a percentage. So it wasn't like a set premium amount, it would just be a percentage of your income, which is automatically taken out, just like taxes. And then you could just go to any doctor, clinic, whatever you wanted. So it was so simple, but it was all based on a percentage point.
And did you hear it? Some didn't hear that. She was saying that she lived in Australia 30-some years ago, and their premiums for healthcare, their payment for healthcare was just a percentage of your income, a very simple system. And ours would be that, except, you know, if you're making $10,000 a year and so on, saying whatever, if it's 8% or whatever that you would have to be collecting out of this, or 5% or whatever, it's a lot easier for somebody at the top end, even though they may be paying 20 times as much. It's a lot easier for them to do it than at the low end, so we want to have a lower percentage. So it would be simple numbers. You'd look at the chart, here's how much you're making, here's how much you're paying. And we wanted to count not just earned income, like in Social Security, but we wanted to count earned and unearned income as well. But it'd be simple. It'd be a chart you look at, and here's how much we'd be paying. And the simple thing is you're not paying co-pays or deductibles. You don't have to worry about out-of-pocket expenses. Other things? Yes?
Hi, so I'm going to be caretaker for my mom, again, coming up for more cancer treatments, but she is 10 years previous to retirement. So she's been terminated from her job, and we're trying to figure out when her COBRA runs out in January and what to do. So I guess this is more of a request than a question, is to better fund disability determination services in this state, because that was shocking to me that I didn't realize that Social Security disability is determined at the state level. And as a state employee and a MAPE member, actually, they're across the street from me and in my local. So I've heard about what's going on at DDS. But we really need you fighting for DDS up at the Capitol because it's miserable and my mom got denied twice and now we're waiting 17 months for an ALJ in Hennepin County to get her appeal and her COBRA's gonna run out before we even get there. So I don't even know what to do with her case now, but if we could get Social Security, we could have Medicare.
It's very helpful. Please feel free to contact my office. I'd love to follow
Oh,
up.
I already have a letter drafted that you'll be getting.
Okay. The whole thing we do with our system is really messed up. And the one point I think is very important, because people say, John, if you're not going to get this next year, we got a crisis right now. And the one point I always try and make to colleagues and others is pushing for a big plan like this is no excuse for not working on incremental changes right now and trying to fix things right now. It is extremely important to do that, and I can tell you I spend a lot more time on those incremental changes because we have to do that. I'd make the same point the other way around. Working on those incremental changes is no excuse not to fix the big picture. And I'd say we have an obligation to do both, but yours is one of thousands of stories that it's a terrible
I
waste.
want everybody to have my health care that I have in the state. It's great.
Yeah, and it's bizarre. The other thing is, the one thing, when we had a news conference this year for the bill, we knew we didn't have a chance, but the 60 co-authors, we thought, you know, we're all talking about health care, Trump administration's planning to do all this other stuff. We said we should have a news conference on it, and I predicted ahead of time the first question I'd get from the reporter. First question I got from the reporter was, you know, well, this is what you would, wouldn't this be what we got if Democrats won? Isn't it that the public doesn't want government-run health care? And I'd say, this isn't government-run health care. I mean, did you read the bill? I mean, this is patient and doctor-run health care. What we have now is government and employer and insurance-run health care. And a couple of years ago, Hobby Lobby made national news because they were trying to tell their female employees what kind of health care you want. It wasn't that narrow of a focus. A lot of employers do that, including health employers. Alina just had a strike from their nurses last year because they wanted to say you can only use these clinics and only use this, and you got to get this kind of care. We're going to limit you to that. And I keep thinking, I have a real problem with that. I don't think my employer should have any business about what kind of health care I get. Nor do I think insurance company or government can. And again, it's not like we're all racing out trying to get more health care. We really don't like it. Are we out of questions? 5 minutes.
Unless you're out of questions.
Okay, well, if we're out of questions, you can wrap it up and so on and whatever. Anyway, oh, one more, yes.
Yeah, just quickly, do you know if any of the candidates, the people that have announced candidacy for governor next year, if any of them would be supportive of this plan?
Of the candidates for governor running right now, I'm kind of working with a lot of them, trying to encourage them to be more vocal in terms of this. There are some who are more supportive than others. I'm trying to get firm. I don't care if they say, I'm going to vote for John Murray's Minnesota Health Plan, I'll make it happen. Mark Dayton actually said that 8 years ago, and once people get into office, they sometimes, well, I got to look at all these other things. I don't want hollow promises and so on. I want to have people who really mean it and figure they'll do it. So I'm working on them, and I hope to, I'm not endorsing anyone right now. I'm just trying to push them all to do it because realistically, they don't have any option. If you look at our healthcare budget, our Health and Human Services budget, it's breaking the bank, and it's continued to go up. And the only way we cut it is to say, well, we'll cut back from what all people are covered for. Chemical dependency treatment, we cut back a couple of years ago. We keep cutting it back, and that's only making people sicker. And our theory, at least a lot of people's theory in politics, is if it's too expensive, well, we'll not provide coverage. When Tim Pawlenty took the very sick Minnesota, General Assistance Medical Care, 35,000 very sick people. He said that will save $104 million, I think. Why? Because that's what the program costs. And I said that analysis is good only under one condition, which is a phony condition. And that is, it would save $104 million if those 35,000 very poor, very sick people would cooperate and stop getting sick.
Yeah.
And they don't stop getting sick, and they do go to the hospital, and we do pay the costs and so on. So anyway, I appreciate the attention. I hope this is helpful. I'm happy to answer questions individually later, or and check out the book online or here or whatever. But thank you for your attention. And
we're really grateful for your sharing with us tonight and your work at the Capitol. And hopefully through this new organization, we are now calling ourselves the Roseville Area Advocates for the Minnesota Health Plan, which is Senator Marty's legislation. And there are happily chapters springing up all around the state. So we are part of a grassroots organization where hopefully we can be that drumbeat to help. We don't have to really beat the drum in our own district with Representative Alice Hausman and Senator John Marty both being strongly and legitimately for this, but we can help. There's other areas, other legislators near our area, and we can help just in general with the loud voice in the state. So Charlie Quick at the very end of the program will be talking about our next meeting, and John Marty mentioned that the Minnesota nurses are a strong advocate, so I think you'll enjoy the next meeting that he will tell you about at the end. But before we get to that point, in addition to all these chapters springing up around the state, of which we are now one, our umbrella organization, the Healthcare for All Minnesota, HCAM, is that how we're pronouncing it, has sent us one of their board members who's going to tell us in a nutshell what they are doing to organize and help coordinate organization. We're looking for action, and so she will tell us about their action plans. As Senator Marty said, this has been studied for years and years and years. And a lot of that really good study was done by this organization, and now they, like us, are ready for action. So I guess I have to turn this over to you. And after Ann, this is Ann Jones, and after she gets done talking, then Charlie Quick, you can seamlessly come up here, and you started the program, you can conclude it. So Ann, thank you for being here.
You're welcome. We are very excited to work with Representative Grayling and Val Swenson, and Roger is here, Cookie. This is an amazing turnout this evening, and we're really thrilled to see this. And we've got to replicate this over and over and over around the state and develop the political will that we need to press for a common sense, comprehensive, affordable, high-quality healthcare system in Minnesota. We can do it in Minnesota. I mean, we have a population that can support it. We have adequate capacity and facilities. We have the ability to educate more healthcare providers as we need them, and we can do that in a planned way, as Senator Marty described. If you read the book, I think you'll be really reassured that this is a realistic possibility for Minnesota and a well thought out plan. It's kind of Health Policy 101 plus a practical transition plan and implementation plan. So we're really 10 steps ahead of, I think, probably a lot of other states who maybe have tried this. Healthcare for All Minnesota is a nonprofit that has existed for over 20 years. It kind of went inactive for a while when the Affordable Care Act passed and the MNsure Law passed, because they didn't sense the willingness in the legislature to press forward on a really definitive solution. But we reactivated our organization, combined a couple of smaller groups with some people who really care a lot about this. I'm a nurse. I've been a nurse for over 45 years. We have health policy people. We have a physician chair right now. And we're teaming up with the Minnesota Nurses Association and Physicians for a National Health Program to try to provide not only the expertise, but the breadth and critical mass of influence that we need. Now we need the political will, and we need the political will in greater Minnesota. So our goals are to educate and engage Minnesota on issues for healthcare financing reform, build a base of support connecting individuals and groups, and that is where you come in, building a base of support, and then work with legislators to pass and implement a Minnesota health plan. So we've got a spread, and this is, I won't underestimate how much work this is going to be. The forces against this change are well-funded, they are ideologically driven, and this will be the fight of our lives. But the trajectory we are on is unsustainable and unacceptable. And I think that the timing is good for us to move forward. So, thank you for coming out. Thank you, who's here this evening, and Joel in the back, and Art, Jack from Healthcare for All Minnesota. We look forward to working with Senator Marty also ongoing in your group to support this work. Thank you so much. We want to speak to anybody who will listen, by the way. So find us places to speak. We need to educate, and spread, especially Greater Minnesota. Thank you.
Thank you, Ron. And thank you all for coming again. Now, the next meeting will be at the 9th of January at the Autumn Grove Park. That's 1365 Lydia Avenue, and that's at Lydia and Hamlin, and that's, I believe it's at 6:30. Is that 7? Okay, that'll be at 7 o'clock. And also, we still need emails. If you come to the next meeting, we can, of course, get your email there, but we're not, like I said before, we're not going to be sending emails out. We're not going to be sending mail out. So the only way to get a hold of you is with your emails.
Can you give us your email or we can send our email?
www.healthcareforallmn.org is the website.
So if you didn't pick up a flyer of ours, you can pick one up on the way out, and that's got the website.
And you can sign up there and give us your contact information. We really don't have the resources to send mail them.
Excuse me, Ann. The Roseville Area Advocates for Minnesota Health Plan, we do have a special email. And if you have your pens ready, it is Ramsey, numeral 4, MHP @gmail.com. Once more, Ramsey, number 4, MHP @gmail.com.
And what we're doing here tonight, one of the things we're doing is informing you of what's going on. And the other thing we want is we want to recruit, we want help for the grassroots effort. So on your way out, if you want to really get involved, let people know where your area of expertise is, and we'll get make sure we got your name and email and a way to get a hold of you. And then we also have a Facebook page at Roseville Area Advocates for the Minnesota Health Plan. Is that right? Just the whole chapter name? And go ahead and get on there and like the Facebook page if you could. That'll give us a little more publicity. And I think anything else the only thing we got left to do is when people start leaving, we need to pick up the chairs and put the room back in order. And again, thanks again. Give yourself a big hand. We had over 75 people here. So.